Good morning and welcome to the third session of the WHO webinar series Implementing WHO COVID-19 Guidelines, coming from the latest update as of 27th May 2020. We have with us in this morning's session Dr. Gary Kuniyoshi and Dr. Sophie Dennis, who are both at the WHO Regional Office for the Western Pacific. And the topic for today is about discharge criteria and patient pathways. So if you recall, we already had two webinars. The first one last Monday included updates on the guidance delivered by Dr. Gary Kuniyoshi. The one yesterday, Tuesday, was about the experiences in a national hospital, highlighting what Dr. Albert Albay Jr. and his team at the UP Philippine General Hospital did, or has been doing rather, to manage COVID-19. Today, the topic is about discharge criteria and patient pathways, particularly relevant as we prepare and upgrade our surge capacity to ensure that patients are moving throughout the system of hospitals and treatment centers, and including staying at home if and when they're already cleared to be discharged. So more on that will be discussed this morning by Dr. Sophie Dennis. Dr. Sophie Dennis is an infectious disease specialist, having been trained in the United Kingdom and also holding several registrar positions in the UK among various NHS trusts and also in Singapore. So having said that, I'm now seeing around 161 attendees. The number is bound to climb in a few minutes. It's quite early. But the format is 30 minutes of a lecture or discussion by Dr. Sophie Dennis, and then there will be 30 minutes of question and answer at around 11:30 onwards. We invite all participants to please use the Q&A feature of the Zoom app. So down at the bottom, there's going to be a button that says Q&A with thought bubbles. When you click on it, you will be able to type in your question. And those who are not typing in questions will be able to see existing questions. And if you think something interests you or that you'd like to join that question, you can click on a thumbs up or a like button that will upvote the question. This means that the moderator, that's me, Dr. Albert Domingo from WHO Philippines, I will be able to see the question ahead of the others. So the more popular a question is, the chances of it being asked are higher. Having said that, so over to you, Dr. Sophie Dennis, for the discussion proper.
Thanks very much, Dr. Albert. I'm happy to be here. Good morning, good afternoon, colleagues around the Western Pacific region. So I'm going to share my slides. Okay, excellent. So as Dr. Albert was saying, following on from Dr. Kuniyoshi's presentation on Monday, it's really looking at the ongoing key updates from the clinical management guidance that the WHO released on the 29th of May, so just over a couple of weeks ago. I'm going to focus primarily on and have a little bit of a deep dive into the evidence and rationale behind the discontinuing transmission-based precautions. So for those patients who have confirmed or suspected COVID-19 and their ongoing management. Then going to have a look at a couple of other areas which are new within the updated guidance, looking at rehabilitation, mental and neurological manifestations in COVID-19, the role of palliative care, a little bit of a briefing note that the WHO released on the use of angiotensin converting enzyme inhibitors and also on the treatment of co-infections. So just having a look at the discontinuing transmission-based precautions, the new guidance is different from what is out there from previously, and it really has removed the use of test-based strategies, so using the rapid testing PCR within the criteria for discontinuing transmission-based precautions. So for symptomatic patients, 10 days after symptom onset and at least 3 days without symptoms, and that means a fever without using any antipyretics and resolving respiratory symptoms. And then looking for asymptomatic patients, so those who have had a positive test, and it doesn't matter in what context that test was taken, but from that first positive test, then we measure 10 days after that. The reason behind this, and I'm going to go into a little bit more detail into what's been released from a research point of view, is that a positive PCR does not necessarily relate to live replicating virus and infectivity. So it's trying to just tease out the difference between the two. We know that PCR is still necessary and validated in initial diagnosis of COVID-19, but it doesn't have such a role in determining when the patient is no longer infectious. It should also be noted that the discontinuation of transmission-based precautions and release from the COVID-19 care pathway does not necessarily mean that's when the patient is discharged from the facility. So if they're still requiring ongoing care beyond release from this COVID-19 care pathway, that is continued, but just looking at the transmission-based precautions, primarily looking at sort of personal protective equipment with that. So the first paper I wanted to review, and there's two of them, is one from China, carried out in Wuhan, and that looks at the clinical data on viral shedding with separate epidemiological data on the incubation period and the serial intervals between cases in the transmission chains, and to draw inference on the infectiousness profile. So the top right is looking at 414 throat swabs that were taken from 94 patients, and you can see just of the CT value going up the axes there compared to the days after the symptoms onset. So looking at that high viral load, which is typically seen earlier on and then tails off, there was still detection towards around day 21, and other studies have shown positive viral shedding noted on PCR up to 37 days following the onset of symptoms. So looking at the bottom right picture, this is modeling, and this is looking, estimating that 44% of secondary cases were infected during the index cases pre-symptomatic stages. So from data that is available, looking at epidemiological studies and combining that with what we know, it looks like the most infected stage is around the time of onset of symptoms or a couple of days before that. So just moving on to the second paper. So this is one that was published in April in the Nature journal, carried out in Germany. And this is looking at virological assessment of hospitalized patients with COVID-19. Again, bottom left, you can see a graph looking at the copies of RNA that have been isolated, correlating that against the days after onset of symptoms. Showing similarly to the previous one, showing that it starts to tail off, and by about day 20, then you're not having ones above the threshold for being detected. What we then compare that to is the one on the right, and this is looking at active virus replication in tissue. So that's what we would use as the gold standard measure of infectivity. So whilst PCR can pick up just small fragments of the virus, this is really looking to see whether you can culture and that virus is able to be infectious in nature. So the pharyngeal viral shedding was very high, as we would see during those first weeks on the left, but you can see after day 8 from onset of symptoms, they weren't able to then culture any replicating virus. So this is really showing that correlating between the two, that whilst there was still ongoing high PCR detected, it is not being replicated, and this really has helped produce the guidance that WHO is now recommending. It should be noted as well that the CDC and other institutions are also producing guidance that isn't requiring test-based strategies for the discontinuation of transmission-based care. So we'll move on to the other topics, but happy to take any questions at the end regarding that. So having a look at rehabilitation. So this is going to be something that's key and ongoing, but also during the times when there are high numbers of patients that are being cared for, it's going to be stretched in its services. And I know that the workforce that comprises what is meant by rehabilitation is different within different contexts and in different parts of the world. But really what it is trying to create tailored rehabilitation for specific patients and targeting really those or being very aware of those who are being discharged from the intensive care unit. So they may have prolonged stays, prolonged bed rest, requiring mechanical ventilation and sedation, and really resulting in physical deconditioning, including their respiratory effort, their swallow, and their cognition and mental health, which that's a separate issue that I will come on to shortly. So those really need to be considered, especially in those that are elderly with comorbidities and who have more complex requirements. So it's this multidiscipline approach, involvement of physiotherapy, occupational therapy, speech and language therapists, and mental health and psychosocial providers. Looking at the patient from prior to coming in, what their pre-admission status was, what their social situation is, what informal care they have available, and whether that's appropriate going forward. And then looking what those needs are, how they can be met, and where is best to continue this care. And I appreciate they may not require further inpatient care. It may be community-based or as an outpatient-based. It's really making sure that these facilities are in keeping with infection prevention and control measures as well, to make sure that the continuity for the patient is safe ongoing as well. So having a look, as I mentioned, from the COVID-19 point of view, mental and neurological manifestations. So we know that in many cases, neurological manifestations have actually been reported even without respiratory symptoms. And this may be particularly in the elderly population or those with comorbidities or who are polypharmacy, so taking many medications, which just means that they have that lower threshold for entering into, say, a delirium. Other neurological manifestations noted in COVID-19 is encephalopathy, agitation, meningoencephalitis, and anxiety and depression, which I've got as the next point further down. So an observational case study that was carried out in France found that 65% of people with COVID-19 in the intensive care unit showed signs of confusion or delirium, which is not unexpected, and 69% experienced agitation. We know that delirium in particular has been associated with increased mortality and in the context of COVID-19, and it's really trying to take measures to prevent the delirium as the first instance. So that's ensuring that if there is the signs of any underlying co-infections, that these are treated early, monitoring oxygenation and fluid status, correcting any metabolic or endocrinological abnormalities early, and really rationalizing the use of medicines to avoid polypharmacy and minimize the effects of drug-to-drug interactions. For patients receiving invasive ventilation, trying to minimize sedation with targeted specific titration endpoints or daily interruptions of continuous sedative infusions, just to try and help with this is going back, I guess, to the rehabilitation as well, but just to encourage early progression. And for patients who are experiencing agitation, if other measures in terms of just trying to using calming methods aren't appropriate or aren't working, and trying to reorientate the patient, then there is the consideration for short-term use of medicines, and this will depend on where you're working, but one is such as haloperidol, but really trying to minimize the dosing and the amount of time that it is needed. So moving on to anxiety and depression, a study, and this was done in China, revealed that 34% of people experienced symptoms of anxiety, and 28% had experience of depression. And this is multifactorial, and it's really always to be considered. I know as clinicians during this time, especially when there's high prevalence, time is a limited commodity, and it really takes time to try and assess how the patient is. But in the long term, this will have great benefits for the patient's recovery as well. So things such as worries for their own health and health of others, and often the need for physical isolation away from those, and it makes people feel helpless. They can be bored or lonely, and it's really just considering what psychosocial support strategies there are based on the principles of cognitive behavioral therapy and relaxation treatments that we can provide patients. And finally, so mental health and psychosocial support leading on from that, it's asking people about their needs and their concerns around the diagnosis, prognosis, and COVID-19 on a wider sphere, and helping to link them with relevant resources and services ongoing, not only within the hospital facilities, but also on discharge as well. So looking at palliative care, this is going to be something that needs to be broached now and early, and looking forward, hopefully it can be something that is instilled within the culture to be talking openly about advanced care planning. So looking at the patient's wants and wishes with specific things such as intensive care support, and do not resuscitate status. So in China, over 80% of the deaths were occurring in those over the age of 60. So that's not saying that we should be ageist, but it really is something to be evaluated on all fronts. We know that from COVID-19, some patients can deteriorate very quickly and rapidly, and it's trying to have these conversations early so that we know what the patient's wishes are. Ideally, these conversations to be held in the community beforehand, but appreciate that, again, during this time of the COVID-19 response, this is difficult. And the palliative care is not only looking at those right at the end of life, but it's looking at the patient holistically. It's seeing what we can do in terms of early identification, assessment, and treatment of not only physical, but psychosocial and spiritual stresses as well. Interventions can include medications, equipment, specialist involvement, and that social support. And it really must be emphasized that you don't have to be in a designated palliative care facility. It's something that should be broadened out over all care settings, and should be there to be provided when needed. So having a look at a scientific brief that was released earlier last month with regards to the use of angiotensin converting enzyme inhibitors, or ACE inhibitors. The reason why this has been brought up, and I know it was actually brought up in the call on Monday as well, so I thought it would be worth covering, is that there are concerns as to whether these agents can increase susceptibility to the SARS-CoV-2 and the likelihood of contracting severe COVID-19 and associated mortality, with a hypothesis that the ACE inhibitors can act as a potential risk factor for upregulating the ACE2, which we know is what the SARS-CoV-2 binds to. So there has been some preliminary data that looked at characteristics from China, that those with, and globally, that those with diabetes, hypertension, and cardiovascular disease are more prevalent amongst those who are contracting COVID-19, with associated poorer outcomes. And understandably, many of these patients are or are on ACE inhibitors or ARBs. After adjustment for co-founders, actually, it was noted that there hasn't been an association with increased severity of COVID-19 illness. So that's why the WHO has come out with the recommendation that there is low evidence to suggest that the ACE inhibitors are affecting poorer outcomes. And if you go back, there is abundance of literature and solid evidence showing the mortality lowering effects of the use of these medications in cardiovascular disease and prognostic benefit in heart failure therapy with the highest level of evidence with regards to mortality reduction. So it is not our recommendation to be stopping these at this time. As with an evolving disease such as COVID-19, these things will always be revised, and it's good to keep updated with the new literature that's coming out. So please be aware of that. And finally, again, another thing that was brought up on Monday is just having a look at the treatment of co-infections. I know within different regions, so leptospirosis was brought up on the call on Monday, especially with regards to the rainy season, and with that dengue, and in other areas you have malaria or high prevalence of HIV. There's no specific guidance that's come out with regards to this, but it's always to use your clinical acumen and make sure that you're considering alternative diagnoses, or at least having them at the back of your mind if they are endemic to your region. Antibiotics, and this is looking for the acute consideration of co-infections. So I guess antimicrobials as well, if influenza season is also coming into play. But we know that the overuse of antibiotics can increase the risk of multi-drug resistant bacteria, and the associated mortality, morbidity, longer stay for patients, and financial consequences for healthcare facilities as well. So it really is something that we try to avoid as much as possible, and having a look at what's available. For mild COVID-19, WHO does not recommend any antibiotic therapy or prophylaxis. For moderate COVID-19, this really needs to be based upon clinical suspicion of a bacterial infection. This isn't hard and fast rules, but it's there as recommendations and considerations. So in severe COVID-19, a patient who's potentially presenting with a septic picture, alongside the sepsis bundle that will be started when the patient first comes into hospital, we would want to be starting antibiotics within the first hour of initial assessment, if possible, taking blood cultures as well, and trying to get as much biological, microbiological evidence as possible to back up if there is any co-infection at the same time. And so once antimicrobials have been started, again, a difficult thing is regarding de-escalation, but the plan is to do that as quickly as possible and as safely as possible based on clinical judgment and microbiological results, which are hopefully taken early on. Switching from intravenous to oral antimicrobials and targeting those based on the results available. So the guidance is with a pneumonia to keep the duration as short as possible, generally 5 to 7 days, but this needs to be taken on a case-by-case basis. And the use or the choice of antibiotics will again be guided by local epidemiology and susceptibility data, and what the guidance is there. So just considering what antibiotics are appropriate, their indication, the spectrum of activity that you're wanting to cover, and the potential for increased antibiotic resistance when prescribing these medicines. Particular vulnerable populations, including the elderly, those in long-term care facilities where there may be increased risks of certain more resistant strains, and also children under the age of 5 just need some special consideration as to choosing the appropriate therapy. Thank you very much.
Thank you so much, Dr. Sophie, for that presentation. So we have now 307 participants, and I'm seeing, okay, a few questions, just one. Yeah, actually, the anonymous attendee. So I'll go straight into the questions, but before that, a reminder to everyone, there is a Q&A button at the bottom of your screen of the Zoom app, and it's the best way to type in your question. If you see an existing question inside the Q&A box that you also want to join, like I'm seeing now, a lot of people are clicking the upvote on the question about dexamethasone. So yeah, we will go to that in a bit. Just a reminder. So if you are on the Zoom, use the Q&A function. Wow, I'm just impressed that the number of upvotes on the dexamethasone is like going up and up by the minute. Anyway, so I'm just prompting Sophie and Gary that they do want to ask. Let's ask it anyway. So recent news say with dexamethasone, it helps in treating COVID-19. What is the stand of WHO on this matter?
Sorry.
Thank you very much. I can see that from that question, there have been so far 51 likes. So yes, very topical, came up in the news yesterday and really has just been, it's a study that's coming out of the UK, a randomized controlled trial that's been looking at different medicines. One of them of the trial arms was the use of dexamethasone. So this is hot off the press. We don't yet have even sort of preliminary results. It was really just the suggestion that this is beneficial. I'm going to hand over to Dr. Gary, who was on a technical call yesterday, who discussed this in a little bit more detail. But it is very early days. We can't yet at this stage recommend it. It's too early to say so. But if there are any advancements with this and the scientific backing to suggest that there is indeed effect or reduction in mortality rates with regards to the use of dexamethasone in COVID-19, the WHO will be updating its guidance based on that. Gary, over to you.
So yes, let me reiterate what Sophie just mentioned, that WHO does not have a guidance change on the use of steroids for COVID-19 yet, but it is something that is being looked at very actively, and there may be a change coming up, but it's not out yet. So what does this mean? There were interim results from this large randomized controlled trial that came out last night. We were given some additional information on it. I think I can share some of the numbers that were given. These were all reported to us from the recovery trial investigators. So this is a large trial from the United Kingdom. They enrolled about 11,000 patients in the trial. They were looking at 6 different therapeutics. One of them was dexamethasone. Once they reached about 2,000 participants in the arm of the dexamethasone group, then they stopped enrollment and then they looked at their 28-day mortality. They were able to do that about 2 days ago. And then with that, when they looked at their 28-day mortality, then they released some of the early results. And the initial effects looked like effect of dexamethasone in their COVID population reduced their risk of death of about 17%, with a very significant, it's called a p-value. Next, when they stratified the patients according to their severity, so their need for oxygen, the patients that did not need oxygen did not benefit. And the other 2 groups, one was an oxygen group that just required supplemental oxygen. Then they had another group that required, that were in the severe or critical category that did require either ventilatory support or ECMO. Both of these groups showed reduced risk of death, according to the investigators. The oxygen group, the risk of death lowered by 20%. And in the ventilator or ECMO group, the risk of death lowered by 35%. This was reported to us last night. And then the trial investigators did put out a press statement. WHO is looking at the data that were submitted at this time. Presently, the recommendation in regards to steroids are that
Gary, I think there are audio problems on your side.
oh, were you able to hear
Here,
me?
here. Yeah. You're back on. Okay. You were saying something the past 5 seconds.
Okay. No, I was finished.
Oh, okay. All right, got it. All right. So I just wanted to echo what Gary said. So the way things go, the findings are literally hot off the pre-press. So it's not yet like peer reviewed. It hasn't been published in a journal yet, but because it is something which may be beneficial, and in the interest of transparency, it was disseminated last night Manila time. The way WHO works is this is well received. It's going to be analyzed further. We can't be overcautious when it comes to dexamethasone, which actually leads me to next series of questions. And this is probably the reason why WHO is taking a cautiously optimistic position in receiving this information. Maybe Gary and Sophie, can you tell us about is dexamethasone readily available? What are the side effects? And why should people perhaps not like readily jump to the nearest drugstore and get dexamethasone based on what the preliminary findings are saying? I mean, I heard from Gary's report that the effect was observed only in those patients which are on oxygen support, particularly those who are on ventilators. So can you tell us more about that and why we are being cautious? It's not yet part of the official guidance, but since people are quite interested, how should it affect behavior? Over to you, Gary or Sophie.
Thanks, Albert. So I think, again, to just reiterate, the ongoing need and how we got this data is through a randomized control trial. So until we have data available, we would always suggest still using dexamethasone within a randomized control trial so that we can get more data from it from that side of things. Dexamethasone is used in a myriad of other indications. So depending on most regions, and I believe we only have one country within the Western Pacific region that hasn't licensed dexamethasone use for clinical use. So its use can be in, I'm just trying to think off the top of my head, it's a steroid. So reducing cerebral edema, especially used in oncology very readily. What was your
Adrenal insufficiency.
Adrenal insufficiency. So whilst it's a medicine that luckily we know quite a lot about, it's also one, as it is a corticosteroid, that has many side effects. So that causes uncontrolled hyperglycemia or difficulty with controlling sugars. The longer term use of it or use of it in high doses can cause psychosis. The list is long. It can cause osteoporosis. These are all just off the top of my head, and it is really worth looking into that especially prolonged use can have significant adverse side effects and affect morbidity. So not one, as you say, Albert, hopefully you're not able to be able to buy it over the counter from a pharmacy, but one to really sort of just be cautious and tread carefully, and the WHO will remain transparent and update its guidance accordingly. Thanks.
Thank you, Sophie. So that was a very good point. It's really an exciting development, and we all want to save lives. But as physicians and medical professionals, health professionals, we also have to remember we should first do no harm. So we have to be careful in proceeding with these things. I'll just quickly answer 2 questions that are related still to dexamethasone. So an anonymous attendee was asking about mechanism of action. Does dexamethasone help in the cytokine storm? Hence, there's no effect on the mild COVID. So, I mean, echoing what Sophie and Gary essentially said, we still don't know at this point because it's really fresh data and we are coming from clinical trials. So as to the mechanism of action, that's a further deeper study that has to be seen. So for that question, that's the answer. And then there's another question, what about the use of steroids for symptomatic management of, for example, headache and myalgia? So I'll just take the chance to answer on behalf of Sophie and Gary that existing guidelines as established already for those particular conditions for the steroids are still in effect. So please use your clinical judgment in using them for dexamethasone rather for its original indication. Not yet for COVID-19, pending further guidance as it comes along. All right, so having said that, we will now jump to one particular issue, which is also quite pressing, particularly in the Philippines and I'm sure in other countries, the use of the testing for discharge criteria. So let's begin with a question from an anonymous attendee asking, when would you recommend to be the best time to do a swab? So Dr. Sophie or Dr. Gary, when should be the best time to clinically get nasopharyngeal or oropharyngeal swab for testing?
Thanks. So that really depends on the context as to why the patient is presenting or why you're doing the swab in the first place. So in the clinical setting, if a patient's presenting with symptoms suggestive of COVID-19 or have a fever with unknown foci, or they're high risk with contact to either suspected or confirmed COVID-19, or where there's widespread transmission, then we wouldn't suggest delaying doing a test. So we would be suggesting that's carried out when the patient first presents. I'm not sure if the question was looking more into the wider sort of from a contacting tracing side of things, but I'll leave it at that from a clinical side. Thanks.
All right. So, but just to follow up, because I'm anticipating that it will be a pressing question, Dr. Sophie. So if, for example, if an asymptomatic individual comes to the testing center and says, I'd like to find out if I have SARS-CoV-2 or the virus that causes COVID-19, just a hypothetical question. So if that happens, what's the best advice? Should this individual be, tested outright, or should we just wait for symptom onset? Or given the things that we know now about the viral load over the number of days over?
Thanks, Albert. I might defer to Gary unless he knows a little bit more. We've been looking at it more from a clinical aspect. I think, again, where there's widespread transmission, we can't ever say that anyone is lower risk. Usually there should be some reason as to why they're suspected. But we think the incubation period is 5 days up to 14 days. So it's difficult to comment any further than that. Gary?
So what we do know is that virologic and clinical studies, when they've done repeated sampling from symptomatic patients, is that the SARS-CoV-2 virus load was the highest within the first 3 days of symptom onset. And then it goes down after that. So you're going to have the best sensitivity for your testing within the first 3 days of your symptoms for your PCR testing. After that, it goes quite a bit down. And also the asymptomatic patients, they may have a very low sensitivity of the testing.
All right, so that's kind of clear. It still depends on the clinical decision of the physician or the health worker, but it's really based on the data that we have thus far, the 3 days after symptom onset, around thereabouts. Okay, so related to that, Jennifer or Jennifer Din is asking, how about asymptomatic patients? Are there studies regarding their infectivity or viral load? Are they less? And I think the question here is, are these asymptomatic patients less infective, hence lesser amount needed for the time to isolate?
Thanks, Albert. This is difficult, and asymptomatic patients as a cohort are inherently difficult to follow up from an epidemiological point of view because of the nature of the fact that they're asymptomatic. What some studies have shown is that those with more severe COVID-19 have higher viral loads, especially in those initial days, but this hasn't been across the whole the whole research community. So it's an idea, but hasn't been agreed upon. So we don't have any further comment on that at this time.
Right, so it's really difficult on the matter of asymptomatic patients. I just wanted to echo what Dr. Sophie said, because if we are to give an answer based on data, to begin with, it's hard to gather data from the asymptomatic patients, which brings me to a next comment by Kat Duke-Lee, or a question rather from her. How do you trace contacts of confirmed asymptomatics? What is the time frame and the basis behind it, since they have no symptoms to be the point of reference? So, I mean, I just wanted to quickly answer the question based on what I've heard from Dr. Sophie and Dr. Gary. It's really difficult to pinpoint which day, insofar as the asymptomatic patients are concerned. And partly this is probably the reason why most ministries of health and also the WHO, the guidance is focused on the onset of symptoms, because that's the strongest set of data that we have at this point. Now, further to that, another question comes from Gerald DL, and the question goes like this. In the Philippines, COVID patients who are for discharge are no longer tested for RT-PCR for clearance purposes, but instead they are to be put in isolation for 14 days. The question is, does this mean that COVID-19 survivors, or those who have recovered, are no longer contagious or will not spread the virus through droplets? Are there COVID-19 survivors who were reinfected? So Dr. Sophie or Gary?
Thank you very much. So this question really goes back to what I was discussing with regards to the WHO recommendation for discontinuation of transmission-based precautions. So what we have seen is that if a patient is confirmed to have COVID-19, from when that test is taken or from the onset of symptoms, what we would say is that 10 days following this, they are considered to no longer be infectious. And the data from this is the fact that looking at patients, they have not been able to culture this replicating live virus 8 days after the onset of symptoms. So I'm not sure, and I can't comment on the further 14 days of isolation on discharge following this, but we would not consider them infectious anymore. Thanks.
Right. So Dr. Sophie, you mentioned something interesting and something that I'd like to reinforce. You mentioned about replicating viable virus. So did we hear it correctly that after the 8th day, the research shows that it hasn't been easy, or what is the word? So they weren't able to replicate, to reproduce a viable virus. Is that correct?
Exactly. So they weren't able to culture it following 8 days after the onset of symptoms.
And this may sound like I'm cross-examining Dr. Sophie, but it's also going to help to clarify. But Dr. Sophie, RT-PCR by its nature does not replicate a viable virus. Can RT-PCR pick up like portions of a dead virus, so to speak?
Exactly. So it picks up just a fragment of the sequencing on the virus. So it cannot state it. It can't give any indication as to whether that virus is live. It just means there are fragments, or there is inactivated, or there is indeed in some portions for those who are early on on the onset of their illness, some live virus. So it just suggests that it is still within the culture of where you've taken it from.
Right. So, I mean, thank you. Ladies and gentlemen of the jury, if I may say so, the reason why I'm doing it like this is to make it a bit lighter, but still anchoring it on the evidence that we have. So I'm seeing a lot of questions asking about, so isolation, what are we going to do? Should we still repeat the RT-PCR test for an asymptomatic patient who has been isolated for 2 weeks now, asymptomatic all the time, but still, do we need to repeat the RT-PCR test. So to paraphrase what Dr. Sophie said and what we are reading from the evidence, you still might test as positive on RT-PCR even if you are no longer infected. Remember, the data shows that from the 8th day onwards, they meaning researchers haven't been able to culture viable virus that can infect people. So I wanted to emphasize that based on the current information we have now. And this is the reason why the discharge criteria has been modified to, I think, 10 days. Is that correct, Sophie? 10 days.
Correct.
Right. So the data shows 8 days, but the guidance says still 10 days of asymptomatic, nonstop from day 0 to day 10 of observation, asymptomatic findings in the patient. So I'm going to use that to answer the questions already. So I'm clicking it. When I say answer, like I'm dismissing the questions, but it doesn't mean that the questions haven't been entertained. It's all related to what was been discussed. So let's shift a bit to a different topic, but still related, of course, to the approaches to COVID-19. Dr. Sophie, would you have any recommendations for vaccinations after COVID-19 recovery, like an anti-flu or a pneumococcal vaccine? And related to that, Lucianne Bernal is asking, how soon after a COVID infection can flu or pneumococcal vaccinations be administered? So you have a patient here recovered from COVID-19. And is there like a timeline after which you can only give further vaccinations to these recovered patients? Over.
Thanks, Albert. So it's definitely not recommended, or it wouldn't be recommended that it's given sort of during the acute phase of the infection. I don't think the WHO has produced specific guidance as to when the vaccinations should be given. Especially in elderly populations and vulnerable populations, we definitely want to continue with regular programs of vaccinations, and that's really being pushed globally to ensure that the overall health of the population is optimized. But I don't know specifically sort of how long should be waited after the acute illness has resolved. Thanks.
Right. Okay. So thank you for that, Dr. Sophie. And then I'm seeing this is interesting. Thank you. So there's actually a question, and then someone volunteered to answer the question through the Q&A, but it does help. So Lucianne Bernal is asking, are there any resources on mental health or well-being programs for COVID-19 inpatients, their families, as well as healthcare workers that we can use to develop programs locally? So before I turn over the question to Dr. Sophie and Dr. Gary for the broader answer on the regional basis, international basis, we actually have a helpful reply from, I'm assuming this is Dr. Adith Afuang. She would like to venture to answer this in the Philippine setting, that the Department of Health, in partnership with WHO, and all in the MHPSS, Mental Health and Psychosocial Services Cluster, have materials or references that we can share. So, for Dr. Bernal, you will be able to see this this reply rather, inside the Q&A answered, and you can give your email to Dr. Afuang as you would like to. Having said that, so on a regional or international basis, Dr. Sophie and Dr. Gary, what's the guidance out there for the mental health of patients and also healthcare workers? Over.
So there are numerous guidances that are available from WHO. Many of them come under the MHGAP intervention guides. They have several on taking care of patients inside facilities, and also outside with substance abuse issues, dealing with traumatic events. There's a psychological first aid kit that is offered. A lot of these are being, they're on the website, and there's a lot of other mental health products available.
All right. So now shifting to another area of, well, not entirely different, but let's just pose the question. An anonymous attendee is asking, for patients initially presenting with delirium, aside from a history of possible exposure, what other points from the history or from the physical examination may point to a COVID-19 infection. I remember, Dr. Sufi, there was a slide that you were presenting about, I think, neurologic presentation. So I think this is where the question is coming from. Over.
So that's a good question, because we're hearing about a lot of neurological manifestations related to COVID. They generally come under 3 different groups. You have some very mild symptoms, loss of taste, loss of smell, and then some larger, more significant ones, such as stroke or seizures. And then you have delirium. This can present in even mild cases. So of course, ruling out other causes of delirium, but it can be one of the presenting signs, especially in vulnerable populations, such as older persons. They may not present with fever, they may not present with cough, they might not complain of shortness of breath, and their main presenting sign is delirium. So it is something very important to watch for, even as a presenting sign, and not as a sequelae of COVID infection. Over.
All right. So thanks for that, Dr. Gary. I'll just read, this is more of a comment from Sylvia Bernardino. I have a friend tested for a long time in Sydney, treated rather, for more than 80 days, and she was really very serious for about 70 days in the ICU. What impressed me is that the healthcare worker did not give up as well, and even started her on physical therapy, and rehabilitation was done alongside the treatment. Kudos to our healthcare workers, which included all the departments in the hospital. I think this is also a result of the slide of Dr. Sophie on rehabilitation services, even during this COVID-19 pandemic. So I'll just check that off. And then next question, going back to the therapies or the treatments. An anonymous attendee is asking, do you recommend that the patient who is currently using an angiotensin converting enzyme inhibitor or an ARB, receptor blocker for hypertension, should switch to another hypertension medication? You may have already discussed this, Dr. Sufi, but just to emphasize, should they switch medications if a patient is using an ACE or ARB?
Thanks, Albert. So not at this moment would we recommend switching medicines, and would suggest to review the medicines, but continue if still appropriate. We know about the benefits of ACE inhibitors and ARBs regarding cardiovascular disease. So depending on the indication, we wouldn't suggest stopping it because of the context of COVID-19. Thanks.
Right. So another question related to treatment. So Jane is asking, how about the use of intravenous immunoglobulin in the management of severe cases of COVID-19? Intravenous immunoglobulin.
Thanks. So no comment at this time on that. There isn't the evidence to back it up. It could be considered within the clinical trial setting, but it isn't recommended by the WHO.
Okay, so I'm still seeing, just to give credence to their questions, there are still a lot of questions on the use of RT-PCR and just basing it on, the number of days of being asymptomatic. So I'll just echo what has been discussed earlier because there may be other questions. So as long as the guidance from WHO says that as long as you are symptom-free for 10 days, then you are already eligible for to be tagged rather as recovered. You don't need a repeat RT-PCR test. And there was an interesting discussion a few minutes ago about having viable virus versus picking up fragments of a virus. So the RT-PCR test picks up on fragments of the virus. It is possible for someone to test positive, even though there is no more infectivity as far as that person is concerned. So meaning you can no longer infect people, but you still have fragments of, let's just use a simplified term of a dead virus already inside your system, all right? So having said that, because I just have to emphasize that because there's a lot of questions about it. Now, going back to still on the RT-PCR test, it just shows how big and how important the issue is. I'm just browsing through the questions, and okay, here we go. Aiko Salorzano is asking, when is the right time for a COVID-19 survivor to donate plasma in the case of a convalescent plasma therapy or a call for donations? Is there a particular number of days after recovery? Over.
Albert, if I may, can I go back to the previous question about the discontinuing the isolation or transmission-based precautions?
Sure, go ahead.
10 days and 3 days. The 10 days are after symptom onset. So it has to be at least 10 days after symptom onset, plus at least 3 days without symptoms. So it's 10 days after symptom onset and at least 3 days without symptoms, which is fever and respiratory symptoms. So that is the, we call it discharge criteria. They may not be discharged from the hospital, so it's not the same thing. This is when you release them from isolation or transmission-based precautions. So these are the time-based criteria, and we no longer do testing, as we said. So these are the 2 time-based criteria. So 10 days after symptom onset and at least 3 days without symptoms. In regards to the second question, could you repeat that again? It was about IVIG.
It's about COVID-19 survivors donating plasma, if so requested. Is there a particular right timing, like number of days since recovery or something, for a COVID-19 survivor to donate plasma?
So I don't know the answer to that one. I'm sure that there are some trial protocols that indicate that, but I don't know. Sophie?
Yeah, so again, this isn't recommended. It's still within trial protocol, so it will be depending on what trial and what they're using from that side of things. Thanks.
Right. Okay. So good on that. Now, still, it's really interesting because I'm having difficulty browsing through the questions because a lot are about the. Maybe I'll take the time while browsing to just echo what Dr. Gary said. So it's actually 10 days from onset of symptoms plus 3 days of symptom-free condition, meaning you haven't had symptoms for the immediate past 3 days. And this is not a discharge from the hospital criteria per se, but more of discharge from isolation. Is that correct, Dr. Gary?
Yes, absolutely. That's correct. It may be the same in some cases, but it's not necessarily discharge. Does not necessarily mean release from isolation. Yeah.
Right. Okay. So slightly related, but also a pressing issue. Sylvia Bernardino is asking, if an asymptomatic doctor or healthcare worker wants to restart clinics, is it better to get RT-PCR testing or antibody testing to clear for COVID-19? We're looking at a doctor who wants to go back to work. Should the doctor test using RT-PCR or rapid antibody test?
Can I just clarify the question? Is this for a health worker who has had confirmed COVID-19?
The question itself is silent, but let's just assume that someone who has not had COVID-19, a doctor who just wants to go back to practice after closing clinics in general.
Okay. From this, it would be a risk assessment as to the healthcare workers' potential exposure. So looking as to whether they have cared in the last 14 days, because that's the maximum incubation period for a patient, or being in close contact. So when we say less than 1 meter for 15 minutes, not wearing appropriate PPE, and that puts them at higher risk. There is no testing strategy that we suggest for someone who doesn't have any risk factors. If they have exposure risk factors, we would suggest 14 days of quarantine, or if they develop symptoms or they have a confirmed contact, then it would be going down the correct channels of contact tracing. But just for a clinician or a health worker who's wanting to return to work without any of those exposure risks, we wouldn't suggest testing at this moment in time. In terms of serology and antibody testing, we don't recommend. We don't yet have the evidence to support that.
Thank you, Sophie. And I just saw this question, and I think this needs a clarification. So an anonymous attendee is asking, regarding the issue of discharge, would culturing the virus be the gold standard in the decision-making since RT-PCR, oops, the question moved. Since RT-PCR, okay, the question disappeared. Rather, repeat. In the issue of discharge, would culturing the virus be the gold standard in the decision-making since RT-PCR can detect a dead virus? So I think before Dr. Sophie and Dr. Gary will give their answer, we are not recommending that a viral culture be done to use for decision-making. We just presented data using, so they did an analysis, and Dr. Sophie might be able to explain more clearly. The data is based on isolating a virus, a viable virus, after 8 days. But it doesn't mean that this method of culture or isolation of the virus should be used for clinical decision-making. What say you on that, Dr. Sophie?
Yeah, just to echo what you said, Dr. Albert, exactly that. So it's not being recommended in clinical use. This is more from a research basis so that we can review infectivity. It's beneficial to evaluate the infectivity nature of the disease, but with regards to clinical management, it's not recommended. Thanks.
All right, I realize that the time is now 12:01, but just to wrap up, so maybe a final 1 or 2 questions. So Justine is asking, it's still related to the symptoms, but I think it's important. Does the 10-day rule of no symptoms from onset does the 10-day rule from onset of symptoms plus 3 days of symptom-free status apply to every patient, or are there exceptions to the guideline, like special subpopulations who may still be infective?
To our knowledge, this applies to everybody, but with all recommendations, it needs to be taken on an individual clinical basis. So in terms of if the patient is still spiking fevers, or if respiratory symptoms are getting worse, or the patient is not clinically improving in a way that you would expect, then I can't comment on every single patient, but we are looking at the criteria, including both time from onset and also those 3 days of clear signs of clinical improvement also.
All right, thank you so much, Dr. Sophie and Dr. Gary. Do you have any final comments or final messages before we wrap up today's session?
No further comments, but just want to thank everybody for their contributions with regards to the questions and participation in this webinar series. Dr. Gary?
Yes, also I want to thank the participants for joining in on these webinars, taking time from their very busy day. This is building capacity, and I think this is something that we would really like to see being done here in Philippines. Also, thank you for the great questions. It also informs us on maybe materials that WHO needs to develop or make clearer. So I find this very useful. So thank you very much.
All right, and from my end, thank you so much to all participants. We still have around 287 as of this time at 12:04, already lunchtime here in Manila. And we'd like to take this chance to advertise or to remind the schedule for tomorrow. So tomorrow, that's Thursday, June 18, we will have a guest speaker, Dr. Saibel Abad, who is an infectious disease specialist at the Medical City, a private hospital here in the Philippines, to discuss clinical experiences in the private hospital setting. So remember last yesterday, we had Dr. Albay rather, discussing the public hospital, the national hospital experience. Tomorrow will be the private hospital experience from the medical city. That's still at 11 o'clock in the morning, Manila time, or GMT +8 for those of us who are in other time zones. And then on Friday, the topic will be a discussion on COVID-19 in children and pregnant patients and other special populations. We will have UNICEF and UNFPA with us, together with representatives from the Philippine Department of Health, to join us in that particular session. Having said that, my name is Dr. Albert Domingo from the WHO Philippines Country Office. Thanking everyone, also on behalf of Sophie and Gary for participating. I'd like to just echo what Gary said. This webinar helps us also. Your questions, though hard, and Sophie and Gary might already clobber me offline. Why are you asking these hard questions? But no, that's just a joke. We welcome these questions because it gives us a flavor of what the ambiguities out there are, and we will do our best to work on them and relay them to colleagues inside WHO for possible answers later on in this developing management of COVID-19. Thank you so much, and good afternoon, good morning to wherever you are. Bye-bye.